Good morning. I join with everyone in saying, why did you start at 8:15 in New Orleans? But anyway, I am very pleased to be here, and it is timely. It's an interesting juxtaposition of the work that I've been doing in the last 5 weeks, just totally immersed in the efforts that came out from the president this week, and I will talk about some of that a little bit later. But I'm going to go with what Scott said and sort of the rapid response, because I'm going to spend some time doing rapid data. And forgive me in advance, because I know that you're going to be frustrated at how fast I go through this, but I'm going to leave the overheads with Scott, and you can post them on your website or whatever you want to do. But I just want to start this conversation by giving you a little data. A lot of it you may know, but just trying to set the stage for the conversation about the place behavioral health sits in public health, or the way we sort of think about that these days. So let's see if I can make this work. That would be the first thing. All right, which do I hit? There we go. You have to find the right button. So you will notice that our very first statement that SAMHSA, the administration that I run, talks about is that behavioral health is essential to health. That is first and foremost what we talk about. And you will also notice, if you've sort of paid attention to the national conversation about health care and health reform, you will notice that the word care now is not sort of in the word health reform. And the reason for that is not because people don't care, but it's because health reform is about much more than the delivery of care when someone is sick. It is much more about the public health, the overall health and wellness of the American people. So there is really some challenges and opportunities about that for behavioral health, and I want to just talk about a few of them. There's really not enough time to do a lot, but I hope to just intrigue you a little bit. See, that really was fast, wasn't it? What I want to do is just talk about the impact, behavioral health's impact on public health, just a little bit, some numbers, and then some of the challenges. I want to use 3 examples, and there are many other things we could talk about, but 3 examples. So first of all, a lot of people who aren't in our world don't even realize how ubiquitous, I guess is the right word, behavioral health problems are. They're very common, and they often co-occur with physical health problems. So the CDC is now estimating that almost half of all Americans at some point in their lives will have symptoms of a mental illness, and in this context, that includes addictions at some point in their lives. And about 7% of the population on any given moment has a comorbid physical and behavioral health issue. There are very high rates among medical populations, so the rates of cardiovascular disease, pulmonary disease, diabetes, et cetera, are higher among people with mental health issues, especially some of these data are in Medicaid, but these are also reflected in other issues or other populations. So on any given day, normal people or people without comorbid physical health problems, about 5% of them would have depression. If you have one other condition, about 8% do. Second condition, about 10%, and a third condition, about 12%. So the more physical health conditions you're dealing with, the more depression or behavioral health issue that you might be dealing with. There's a lot of comorbidity challenges that we deal with. Adults who have either mental illness or a serious mental illness or major depression in the last year. People who had these illnesses in the last year also had increased rates of hypertension, asthma, diabetes, stroke, et cetera. So we have a lot of comorbidity that people don't often think about. And the psychiatric medications that we use in our world often help to create, frankly, some of those conditions, and we have not paid as much attention, either as a field of behavioral health or as a field of physical health, about those interrelationships. Behavioral health impacts physical health and vice versa. So mental health problems, so I've just given you some comorbidity data, but mental health problems also affect physical health. So we know increasingly amounts of information about how trauma in young children, and even trauma in adults, but certainly trauma in young children, lead not only to behavioral health issues in adolescence and adulthood, but to physical health conditions in adulthood. So perhaps when we look at that juxtaposition of physical health conditions sort of created by or following from behavioral health conditions, the most interesting piece about this, and there's a lot of other data I could provide you, but just one is the most striking, is the cost of treating the underlying physical disease is more when there's a comorbid behavioral health issue, especially when that comorbid behavioral health issue is not treated. So if you have diabetes and untreated alcoholism or untreated depression, then the cost is almost 5 times as much to treat the physical health issue. Now, the reason that is so critical in 2013 is because the entire country is talking about the cost of health care. And we are working hard in my world, as Jeff said, to try to get the physical health folks who are trying to bring the cost of care down or try to control the rising cost to understand the role that physical health plays in that. One of the biggest issues from both a cost and a quality issue is readmission to hospitals and either in inpatient or in repeated emergency room care. And we're finally getting the point across that mental health conditions is one of the top 5 reasons for readmissions. And in fact, it is about 1 in 5 of all Medicaid readmissions is a behavioral health related issue. I was in a meeting, I think it was in New Orleans actually, not too long ago, in which an emergency room department head said to me that they had just begun doing some data for an issue that we call Partnership for Patients, which is an issue with with emergency rooms all over the country, trying to look at this emergency room readmission and in and out issue. And they'd finally done some data and realized that substance abuse and mental health was one of the top reasons for people reoccurring or coming back into their emergency room, and they wanted to know what to do about it. And I said, well, have you talked to your community mental health center? And there was a little bit of blank stare. So the issue of coordination of care is also in our world and a growing part of our conversation as it is in physical health care. So this just shows you some data about the different costs as the comorbidities happen, and underscores the issue with lots of different data about it's the physical health care costs that go up if we don't treat the behavioral health care costs. We also have worse physical health conditions among people who have behavioral health conditions. So there's an increased rate of smoking, an increased rate of diabetes, and lack of exercise, and poor diet. There's less preventative services. There's less access to high quality care among these individuals. So what you get is that people with mental and substance use disorders are about 2 times as likely as the general population to die prematurely. And the latest data shows that that's about 8.2 years younger than others. And most of that is from preventable conditions like smoking, diabetes, or obesity, those sorts of things. Behavioral health conditions in our country today lead to more deaths than HIV, traffic conditions, and breast cancer combined. We have football players, we have airline pilots and others wearing pink in a very dramatic way in our country to highlight the issue of breast cancer. We have a national HIV/AIDS plan that is very effective there is actually in sight the ability to get a generation of no new HIV/AIDS cases. And until the last week, there really was no conversation about a national approach to behavioral health, even though the deaths are higher than all of those things combined. There's more deaths from suicide than HIV/AIDS or homicides, and half the deaths from tobacco smoking in our country are among people with mental health and substance abuse conditions. So we have a huge behavioral health issue in public health that people are just starting to wake up to. CDC is now reporting that about 2 million Americans say that mental and emotional disorders are the primary cause of their disability, if they see themselves as having that. And the World Health Organization tells us that depression is the most disabling, by far, condition worldwide. And frankly, drug disorders is among the top 10. So we have steep human costs. I'm not going to spend time on these data, but these are relatively new data out of CDC and work that they do about the burden of behavioral health disorders. So people are finally starting, I think, to wake up to that. And yet, this data just blows me away. The public is less willing to pay to avoid mental illnesses compared to paying for treatment of medical conditions, even when they acknowledge that mental illnesses are burdensome, and that in this context includes substance use disorders as well. So in these survey data, the public is willing to pay about 40% less than what they would pay to avoid medical illnesses. So even though we've got the country sort of waking up, and the public health community waking up, and the healthcare delivery community waking up to the impact of behavioral health and those disorders, people are still not willing to pay in the same way that they are willing to pay to avoid medical conditions or to get treatment for medical conditions. The World Health Organization worldwide tells us that mental illness, again, including substance use disorders, accounts for about 15.4% of total burden of disease worldwide, and yet in the United States, mental health expenditures, including substance abuse, accounts for only about 6.2% of our health care expenditures. These data are also really telling, I think, because we talk a lot. If you look at the three pieces on the right, diabetes, heart disease, hypertension, those are the things we hear a lot about all these days. If you look at the proportion of the people in the country who have those disorders who are receiving treatment, it's 75% or more, basically, or 70% or more. If you look at the number of people who have substance use disorders, it's about the same amount as the people having diabetes. Only about 10% receive treatment for that. And for mental illnesses, it's less than half. So we still have a significant amount of untreated, undiagnosed, unidentified mental illness and substance use that are not receiving treatment. The top reasons, if you look at the bottom of this particular slide about why people say they don't get treatment, is first and foremost inability to afford care, and I'm going to come back to that because one of the legal issues in our world right at the moment is the Affordable Care Act and what that's going to mean. So inability to afford care is half the people say that's the reason they don't get care. About a quarter people, a little over a quarter people think they can handle the problem without treatment, and I think to some extent that goes to the inaccurate understanding of mental illness at times, and then not knowing where to go for care and not having time for care. Those are the top reasons that people give in surveys about why they don't receive treatment. The other thing I want to just highlight for you, and again, we could talk a whole day just about this, is an IOM report that came out in 2009 about prevention of mental and behavioral disorders, including substance abuse, and it basically told us several things. Half of adult mental illness starts before the age 14, and 3/4 before the age of 24. So SAMHSA is really taking this to heart. We are prioritizing prevention, and we are pushing hard on that age group under 25. And you will see in a lot of the stuff that just came out this week in response to the Sandy Hook shootings that we're focusing on the 16 to 25-year-old age group, and I'll talk a little bit more about that in a minute. We also know from this report that symptoms appear years before diagnosis or treatment. So if you look at physical disorders, it takes anywhere from a couple months to 6 months for people to start to say they need care. When symptoms arise, it takes about 2 to 6 years for a young person to be identified and get into treatment. We know trauma plays a critical role. Again, we could spend a whole day just on that, but we are starting to learn about the relationship between that and prevention, and we're also understanding the issue of resilience. And one of the ways I like to talk about this is the country needs to spend just as much time teaching their children how to have emotional skills and manage emotions as they do their soccer skills. And if we could do that, I think we'd have much more resilient young people. There are lots of prevention models in this report and in SAMHSA, and we're trying very hard to look at those comprehensive and multi-system models. All right. That was a quick and dirty run through why is behavioral health important to public health. Lots more we could say, but you get the point. There are 3 examples I want to use today. I want to talk about the Mental Health Parity and Addiction Equity Act, briefly called MAPIA. I also want to talk briefly about the ACA. This is also going to be speed dating through laws. But we have these 2 new laws, one of which, MAPIA, was passed in 2008, and then ACA, of course, in 2010. And just this week, as part of the announcement that came out this week, CMS, or that's the Centers for Medicaid and Medicare Services that run both Medicaid and Medicare, sent out a letter to state health officials explaining how MAPIA relates to Medicaid. This is no small thing. It is a huge thing. There's also been an interim final reg produced about MAPIA, but not the final reg yet, and the commitment this week was to get that final reg out quickly. These are going to drive some conversations about what should be in behavioral health benefits and how they should be implemented. MAPIA it is important to understand what MAPIA does and then what ACA does to expand that. So these 2 laws fit together for our world, and We have very little research, very little data yet about how any of this is going to make a difference and what kind of difference it's going to make. And there are a ton of unanswered questions in these areas. So MAPIA, it's really important, was really about big group plans above 50 or more. And it really didn't require that insurance plans provide mental health or substance abuse services. It only said if you provide them, then you have to do it equal to the way you provide medical surgical benefits. So you can do them equally good or equally bad. So MAPIA was not a mandate for insurance coverage. It was a parity in insurance coverage. A huge, huge, important policy step forward, but really didn't give us what we wanted until the ACA came along, and I'll explain that in a minute. So MAPIA covered several things, but again, there were a lot of things it did not cover. For example, MAPIA does not cover basic, regular Medicaid in the country. So it does cover the expansion, and it does cover benchmark plans in Medicaid, but not your basic state Medicaid plan. That is covered by other laws. Parity in the Affordable Care Act goes a step further, and that's why it's so critical. MAPIA is actually referenced in the ACA, or the Affordable Care Act, a number of times. It goes beyond saying you have to have parity and into saying you actually have to cover behavioral health benefits. So we have lots of unanswered questions, and not only does it say it has to cover mental health benefits, but it actually expands who has to cover those benefits. So non-grandfathered plans, and I know a lot of this is probably language that we use in the federal government all the time that I understand, or some of you may understand, but if not, we can maybe get some questions later. This covers not only the plans that MAPIA covered, but it goes a step further and covers individual and small group markets in and outside of the new insurance marketplace that's coming, and in Medicaid benchmark and benchmark equivalent plans, all beginning a year from now. So we're in a year now called Countdown to Coverage. We're literally counting every day to get to October 1st, 2013, which is when these marketplaces open up and people start getting an opportunity to sign up for coverage, and then January 1st when it starts going into effect. Those plans now, so we've moved from MAPIA, which said you had to do it equally good or equally bad if you were a big plan, to ACA, which says not only do you have to do that, but you actually have to cover behavioral health services and in smaller plans and exchanges as well. And as you can see, there are 10 categories that have to be covered. One of them is mental health and substance use disorder services, including behavioral health treatment. Anybody know what that means? We don't either. We're not really clear what Congress meant by those words. There are lots, as laws unfold and as we see what the states are going to do about this, because the states are implementing a lot of this, we're going to be watching and understanding how MAPIA does impact this. So out of this ACA and MAPIA, there's over 65 million people either currently insured but don't have good behavioral health benefits, or currently uninsured who are going to have access to behavioral health benefits they never had before. 65 million Americans. About 11 million of people who are uninsured today we know have behavioral health issues, substance abuse and mental health, either serious psychological distress or substance abuse disorders or minor behavioral health issues, and they're either getting covered some other way today or they have no coverage at all. Also inside the ACA, there's something called the Institutions for Mental Disease, which is an exception to Medicaid that says for adults between the age of 18 and 65, if you are in something called an institution for mental disease, Medicaid won't pay for your care while you're in inpatient coverage. There is a demonstration inside the ACA, and it's going on right now in 11 states and DC, that is paying psychiatric inpatient care for adults who have expressed suicidal or homicidal thoughts or gestures and are determined to be a danger to themselves or others. There is a lot that's going to come out of that demonstration that we will be watching, and a lot of both legal issues and healthcare delivery issues. So those are a ton of issues that are confounding public health officials about behavioral health right now. Second area I want to just highlight is behavioral health IT, or information technology. Behavioral health is really unique in information technology. Obviously, electronic health records is the thing we're trying to push from a technology point of view right now. Unfortunately, behavioral health has much more subjective diagnoses, the majority of non-pharmacological treatments, less emphasis on labs and imaging, a lot more need for strong and continued patient engagement. The role of the family is often different. Social supports, peers, and mutual aid is different. And yet, we have a growing concern about prescription drug abuse in this world. So the interface between healthcare and behavioral health, as electronic health records come online, is important. And yet we have more stringent privacy requirements, especially on the substance abuse side, and across the country, a whole mishmash of mental health privacy statutes at the state level. So the national HIT landscape is a little interesting. The Health Information Technology for Economic and Clinical Healthcare, or we refer to it affectionately as the HITECH Act, was a large national investment in HIT, but providers for behavioral health were largely excluded. Partly the reason is because it's focused on getting money to hospitals and as individual physicians or physician practices. Well, for those of you who work in the behavioral health area, you know that's not generally how behavioral health is organized. It's organized typically a little differently. So in the physician world right now, 57% are reporting that they have electronic health records, with 52% of them being able to apply or applying for something called meaningful use incentives, which means if you use electronic health records in a meaningful way, you get some money for doing that. CMHCs, or community mental health centers, only 21% have electronic health records now, and only 2% of them are able to meet meaningful use incentives. We've been doing a lot of work in SAMHSA at trying to create a marketplace where vendors of electronic health records want to deliver products to our world that will help them be in this electronic world. So if you have a person who's getting substance abuse treatment over here, and you go into an emergency room or into a physical health surgery situation or whatever, and your physician tells you, I want to give you some pain pills, the issue about that relationship between addiction treatment and physical health needs to be able to talk to each other electronically if we're going to do this. And the ACA is putting a significant amount of pressure on coordinated, integrated, patient-centered care in things like, pardon all the acronyms, primary and behavioral health care integration, so PBHCI, a lot of work we're trying to do to bring primary care into behavioral health and behavioral health into primary care. In something I said earlier about Partnership for Patients, which is an initiative to reduce readmissions, and in the Million Hearts campaign, which is looking at heart disease, hypertension, smoking, and those kinds of things. And I gave you the data a little bit earlier about how much of that is in our world and how much of that goes back and forth. And yet, in the country, we have a very low penetration of electronic health records in the behavioral health world, and we have a much more higher and growing penetration in the physical health world. And for the most part, the vendors are confounded about how to do the technology to segment data so that privacy can be protected when there is a state law about mental health records or the federal law about substance abuse records that are different even than HIPAA. So this is a huge confounding issue for us that is everything from care related, legally related, what does it matter related, and any number of other things. HIPAA does include behavioral health, but in addition to that, we have a law called the Confidentiality of Alcohol and Drug Abuse Patient Records Act. We affectionately refer to it as 42 CFR Part 2, because that is the reg that was implemented to implement that law. It was actually passed back in the 1970s because law enforcement was trying to use behavioral health records, substance abuse records to be particular, in order to prosecute. So Congress got into the act and said, no, we're going to really protect substance abuse records in a different way. Now, I really want to take you on a really quick trip here and say, right now, in the world of prescription drug monitoring programs, or what we call PDMPs, by the way, the federal government is the master at acronyms, I have learned, so you have to know your acronyms in order to live in this world. But nevertheless, this whole issue of whether or not law enforcement should have access to records about something that we're trying to create to do better care is a major issue in Congress. And at the moment, those people who want law enforcement to have access to those records are winning. So if you set that over there, this issue came up in the 1970s where law enforcement was trying to use records, paper records at that point, to get access to substance abuse treatment that resulted in this law in the 1970s, and it was consolidated into a single law in 1992, but not changed very much. The reg was written in 1975. Now take just a step back in your own personal history. For those of you who were alive in 1975, did you use a computer? Did you do paper records? Did you do electronic records? Did you have PDAs? Did you have Blackberries? No. So in the 1970s, I was just learning how to do word processing, much less anything else electronically. So this law, which was passed for all the right reasons and which has a great deal of support in the substance abuse community, which basically says not only can you not give out records for substance abuse if you are a treatment provider of a certain type, what we call a Part 2 provider, but you actually could face criminal penalties for doing so if you do it without consent. So, and in addition to that, as I said earlier, state laws vary widely about mental health confidentiality. So this 42 Part 2 CFR or 42 CFR Part 2, we're doing a lot of work at SAMHSA. It may not be what you think your National Behavioral Health Agency is doing, but we're actually creating some models of data segmentation in electronic records so that the vendor world, and we're working a lot with the vendors about this, can use it to segment substance abuse records and yet put them in there, because most vendors at this point and most state health information exchanges are excluding these records. So the very point of trying to take the example I gave you, making sure that after surgery or after dental work or whatever, that we don't give pain medications to someone who's already struggling with that in a substance abuse world is a very difficult and confounding issue. And frankly, there's very little data about exactly how does this work, how does it, what does it mean to people, how would we do it differently, and what would happen as these electronic health records emerge. It's a huge public health issue for us and something that we need additional research in. Finally, responding to disasters and tragedies. Sandy Hook, which is a person-made tragedy that occurred, of course, in mid-December, compared to things like Hurricane Sandy, which is non-person-made, which occurred a couple of months before that, the federal response is bifurcated about which is which. So in a presidentially declared emergency, or which is most often weather-related kinds of things or things of that nature, like Katrina, compared to something like the Gulf oil spill, which is a man-made disaster and therefore not presidentially declared. The law treats those two things differently. SAMHSA's role in it, behavioral health's role in it, the federal government's role in it, the money available to help local communities react to it are different. And frankly, once again, there's very little data and very little information. There's some surveillance data, but not a lot about the implications of that, those differences in these different kinds of disasters. The thing that is emerging is that people are beginning to understand that behavioral health is not something that happens 6 months down the road after a disaster, that it is front and center. And I think actually the BP oil spill was the tipping point for that one. Because it was an extended disaster. It didn't stop. There was no time to say the disaster occurred, the tragedy happened, let's begin the healing process. It went on and on. So in Newtown, Connecticut, the governor was actually in a cabinet meeting when the issue occurred, and he looked at his mental health person and said, "Your point." So for the first time, I think, people got that the very first reaction was going to be a behavioral health, a mental health reaction, rather than some other type of reaction. Unfortunately, with behavioral health issues, we have a tendency to think of them as social problems rather than as public health problems. We have a tendency to wait until we see the homeless person under the bridge, or until, unfortunately, 26 people die in a mass shooting before we say there's a public health issue here. So our reactions are typically, as a society, inadequate. We build more shelters, we build more jails, we involuntarily hospitalize, we do whatever happens after the fact. And if there's anything that this set of tragedies over the last few years, with Sandy Hook being sort of the tipping point for the country, it is a recognition that we have to look earlier in our preparedness response and in our preparedness and response in order to address these disasters and to be prepared for them and hopefully to try to prevent them. Now, we could talk a lot about all of the issues that have arisen in this. I hope that you had a chance to see the President's press conference about the Sandy Hook response. You will note that most of it was about the gun control issues. The response, however, on the website and the public materials that were put out has a significant amount of mental health programs, actions, and other things in it. I was very pleased that the President chose to say one thing in his press conference about the post-Sandy Hook response, and that one thing he said was that most people with mental illness are more likely to be victims than to be perpetrators. And we were very pleased that he chose, of all the things we gave them to say, that was the main public message he thought he personally needed to deliver out of this. We know there's some issues about violence and behavioral health, but we also know that the reaction about it is significantly bigger than the reality about it. And just anytime you have that kind of reaction, you're not going to get at the right kinds of responses that we need to have. So, for example, one of the announcements out of this was an attempt, and HHS will be putting out something called an advance notice of proposed rulemaking, asking states what the HIPAA issues are or what the other issues are that prohibits them from being willing to report into the national reporting system. This is relevant because we only have about 17 or so states that are doing reporting. And so the question is, what's prohibiting that? HIPAA or misunderstanding or a lack of willingness or cost or what? So this is going to be a major thing that I suggest that you watch for. The Brady bill is another major issue. And again, there's a lot of information on here. What I've listed here is the people under the Brady bill for whom reporting should be done. And if you will look at it, people like people convicted in a court of a crime for a term exceeding 1 year. I'm not sure what a term exceeding 1 year has to do with dangerousness. I don't know that there's a particular relationship there. Any unlawful use or addicted to any controlled substance adjudicated as a mental defective, which we're very concerned about how that language in this environment is going to get expanded to looking at things like Social Security records or other kinds of records that could be determined to fall into that category. Discharge from the armed services under dishonorable discharge. What that has to do with dangerousness is unclear. What we do know is that a significant number of people discharged from the armed forces under dishonorable conditions is because of substance abuse and mental health conditions. So we're very concerned about that. Again, I'm giving you examples of things that are confounding us at the moment. The Attorney General has been directed to look at these categories, so over the next little bit, I think you're going to see some conversation about that to make sure that it's dangerous people, not people just identified with a label. But then we get into the whole issue, okay, how do we determine that? How do we determine who's dangerous and who is not, and what kind of reporting would make some sense? There's also some issues, which again, I think you've heard about the research and the congressional language that is in the law sprinkled all over that is absolutely National Rifle Association's work, that has had a huge chilling effect on federal research and on physician inquiries regarding gun safety. And yet we know that half the suicides in this country are committed with firearms, and we know a lot about that relationship, but there's a lot we don't know because of the chilling effect of this language. It limits data collection, and it has more than anything made the federal researchers worried about what to do about this. The CDC is going to get additional dollars that they will be able to put out for research in this area, and some of the policy areas they believe we need to look at is what different kinds of access to firearms, so all that conversation, the technology to prohibit firearms from being used unintentionally or by the wrong person, policies about things that you're seeing in the paper like access to ammunition, enforcement of firearms laws, what difference does that make, firearms safety issues, requirements about that, and expansion of access to treatment. So all of those things are things that I think we need additional research about. These are some of the other areas that are listed as executive actions. I'm not going to go through them, but just so what I want to sort of leave you with is this condition or this situation that we find ourselves in is an incredible opportunity coming out of an incredible tragedy to take the issue of behavioral health within public health forward. So there's lots of points to consider, but I want to just leave you with a couple of ways that SAMHSA talks about its vision. We think of ourselves as trying to have a nation and a community free of substance abuse and mental illness, not just reducing it. That is our vision statement, our mission statement, but our vision is really a nation free of that, or fully capable of addressing those issues as they arise. That we can't have individual or community health without behavioral health. And frankly, it's just as important to protect people from lost hope as it is to protect people from influenza, bacteria in the water, or injury. So thank you very much for listening to me. This was a rapid fire roll through behavioral health and public health, and I really appreciate you having me here. I hope all of you find behavioral health as the next place to do your public health and law research. Thank you.